I am Ramit Lamba. I am Director of CT at UC Davis Medical Center. I have no disclosures. In this presentation, I am going to discuss imaging strategies for non-gynecologic acute abdominal emergencies in pregnancy, focusing chiefly on acute appendicitis, urethritis, and trauma. I will also discuss strategies for dose reduction when CT is used for evaluation. There are several challenges associated with acute appendicitis in pregnancy. It is the commonest cause of an acute abdomen in a pregnant patient and is also the commonest reason for abdominal surgery in a pregnant patient. Clinical diagnosis can be challenging, especially in the second and third trimesters as the uterus enlarges and displaces the cecum and appendix upwards in the abdomen. Due to nonspecific signs and symptoms and delayed diagnoses, there is a higher risk of perforation in pregnancy, and consequently, fetal loss rates and maternal morbidity are higher when complications develop. Also, the nonspecific signs and symptoms contribute to a higher negative appendectomy rate in pregnant patients. Abdominal surgery in pregnancies carries a small but finite risk of fetal loss or preterm labor. Therefore, the biggest challenge in acute appendicitis is balancing the risk of a delayed diagnosis versus the risk of unnecessary surgery, and this is where imaging becomes crucial to establish a timely and accurate diagnosis. So the next question is, what is the best imaging modality for diagnosis of appendicitis in pregnancy? The American College of Radiology appropriateness criteria for diagnosis of suspected appendicitis in a pregnant patient rates ultrasound as the most appropriate imaging test in pregnancy. However, let's look at an example. These are ultrasound images of a 21-year-old pregnant female who's 18 weeks pregnant, and she presents to the ER with a suspected diagnosis of acute appendicitis. Most of us in abdominal imaging are familiar with this situation. Ultrasound images from the right lower quadrant do not show a normal appendix, and no abnormal findings are seen in the images presented. So, does this mean that the patient does not have acute appendicitis? Let us examine the role of ultrasound for the diagnosis of appendicitis in pregnancy more closely. Both the American College of Radiology and the American College of Gynecology endorse ultrasound as a first-line imaging modality for appendicitis in pregnancy. There are some good reasons for this, since it is safe, does not involve ionizing radiation, is easily available, rapid to perform, and relatively cheap. However, there are several challenges. It is highly operator dependent, and frequently the appendix is not visualized, especially in advanced pregnancy. While various sensitivities have been reported for ultrasound, it can be indeterminate in the majority of patients. In a recent important study published in Emergency Radiology, where ultrasound was used in 99 patients in the second and third trimester for the diagnosis of appendicitis, the appendix was not visualized in 97% of the patients, and only 2 out of 7 cases of acute appendicitis were identified correctly. That is, only 29% of positive cases were identified with ultrasound. So it seems that we need a better test for the diagnosis of appendicitis in pregnancy, and that is what brings us to our second choice on the list, which is an MR of the abdomen and pelvis without gadolinium. An MRI is rated as an appropriate imaging choice according to the appropriateness criteria. Next, let us look at the role of MR in the diagnosis of appendicitis in pregnancy. MR has the advantage of no radiation exposure. There are no documented adverse effects for the use of MRI in pregnancy. MR is less limited by the maternal body habitus, advanced gestational age, and variable position of the appendix. In various recent studies, MR has shown a sensitivity of 80 to 100% and a specificity of 93 to 100% for the diagnosis of appendicitis in pregnant patients. Pooled data from the studies shows that the appendix was seen in 52 to 88% of cases on MR, and part of the lower numbers may be related to a learning curve to the use of MR for appendicitis. The MR protocol is fairly straightforward. and informed consent is generally recommended, but I will not get into the details of that. It is, however, important to monitor the study, which will ensure that we get the appropriate coverage of the region of interest and also to minimize imaging time. T2-weighted images in multiple planes are the mainstay for MR imaging in a pregnant patient. T1-weighted images may be obtained as needed. Currently, the use of 3T is not recommended in pregnancy, and gadolinium is labeled as a Category C drug in pregnancy and routinely not used in pregnancy. The T2-weighted images in this example show a thick-walled tubular structure in the right lower quadrant with some intraluminal fluid and periappendiceal fluid, and edema seen as increased T2 signal around the appendix. These findings are compatible with acute appendicitis. This is a 17-year-old, 23-week pregnant patient who presented with clinical suspicion of acute appendicitis, and the initial ultrasound was negative with non-visualization of the appendix. However, based on the high clinical suspicion, a MR was performed which shows a thick-walled tubular structure in the right lower quadrant with adjacent fluid compatible with acute appendicitis. Since the appendix was in a very accessible location, and we were early on in our experience with the use of MR in pregnant patients, we performed a focused ultrasound interrogation using the MR images to guide us, and were clearly able to identify a non-compressible, blind-ending, tubular, thick-walled structure in the right lower quadrant, measuring 10 millimeters in diameter, confirming the diagnosis of acute appendicitis. So is there any role for CT for the diagnosis of appendicitis in pregnancy? Both in pregnant and non-pregnant patients, CT has a high diagnostic accuracy for appendicitis with a pooled sensitivity of 86% and specificity of 97%. However, in pregnancy, exposure of the fetus to ionizing radiation is a concern. Hence, CT should only be performed in a pregnant patient if the ultrasound or MR findings are non-diagnostic, or MR is contraindicated or unavailable. As always, careful analysis of risks and benefits needs to be made, but it is important to emphasize that a CT should not be withheld if it will cause a delay in diagnosis. Again, informed consent is needed, but I won't get into the details of that. Finally, it is important to keep the radiation dose as low as possible, and there will be more on this later on in this presentation. It is important to emphasize that in trying to keep the radiation dose low, we need to be careful to still perform a diagnostic exam, because the purpose will be defeated if we need to repeat the exam. And the use of iodinated contrast is generally indicated for appendicitis even in pregnant patients. In conclusion, when appendicitis is suspected in pregnancy, it is important to avoid a delay in diagnosis. Even though it has limited sensitivity, ultrasound is the initial modality of choice due to its easy availability and safety. MR should be performed when the ultrasound is non-diagnostic. If readily available, MR can be the initial modality for evaluation given its better sensitivity and specificity compared to ultrasound. Dose-optimized CT should only be done when both MR and ultrasound are non-diagnostic and no other options exist. The two images on the bottom left show a CT positive for appendicitis in a 28-week pregnant patient, and the image on the right shows an MR positive for appendicitis in a pregnant patient. The round dark structure within the lumen of the appendix on the MR represents an appendicoate. Moving on to reuterolithiasis, which is the commonest non-obstetrical cause of abdominal pain in pregnancy and also the commonest non-obstetrical cause of hospitalization in a pregnant patient. The good news, however, is that 68% of stones less than 5 millimeters in diameter will pass spontaneously, and overall 50 to 80% of urinary stones in pregnancy will pass spontaneously. So it can be argued that one option is to just use prudence and careful observation to see if the stone will pass spontaneously. However, this needs to be weighed against potential complications of non-passage, which include pyelonephritis, renal abscess, forniceal rupture, or even preterm labor. The evaluation for obstructing stones is further confounded by the fact that physiologic hydronephrosis can be present in 80% of pregnant patients, especially in the third trimester, and this tends to be greater on the right side. Plain radiographs have a sensitivity of about 60% for detection of stones, but the specificity is lower. The radiation dose, however, is low, but hydronephrosis is not detected. Despite all of this, a KUB may be a reasonable choice as the first imaging evaluation for suspected stones in pregnancy. So what is the role of ultrasound in suspected urethritis in pregnancy? Although ultrasound has a low sensitivity given its safety and availability, it is the first-line test in pregnant patients. The biggest challenge, however, is distinguishing between obstructive and physiologic hydronephrosis. Inter-renal resistive indices, when added to the grayscale evaluation, can be helpful in making the distinction between obstructive and physiologic hydronephrosis. Resistive indices in the normal kidney are 0.7. Hence, the diagnostic accuracy of ultrasound can be increased with the addition of resistive indices and urethral jets. Endovaginal ultrasound scanning may sometimes help in the detection of a stone at the UV junction. So is there any role for CT and MR for urolithiasis in pregnancy? CT has an extremely high sensitivity and specificity for diagnosis of stones, with the additional advantage of determining the size and location of stones or any alternative diagnoses. Recent advances in CT technology allow significant reductions in dose, and the high sensitivity and specificity for detection of renal stones seem to be maintained even with low-dose CT. The image on the right shows a 5 mm stone in the mid-ureter in a 29-week pregnant patient. There remains limited data on the use of MR urography for detection of stones in pregnancy. Anecdotal observations suggest that small stones may sometimes not be seen, and flow artifacts can mimic stones. Next, we move on to trauma in pregnancy. Let's start by looking at a clinical scenario. A 20-week intoxicated pregnant female was brought to the emergency room following an MBC. There was an episode of hypotension during hospital transit. In the emergency room, the vital signs were stable. The patient was complaining of abdominal and back pain. On examination, there was mild tenderness in both lower quadrants. However, there was no guarding. There was some tenderness over the lumbosacral spine. A fast scan in the ED showed a viable fetus with a heart rate of 144. Fast scan images from the 4 quadrants of the abdomen are presented and do not show any free fluid. However, given the episode of hypertension, complaints of abdominal and back pain, tenderness in the lower quadrants and over the lumbosacral spine, a CT of the abdomen and pelvis was performed. CT images showed a fracture of the left iliac bone, associated subcutaneous hematoma, and a moderate-sized pelvic extraperitoneal hematoma. This example demonstrates a known limitation of ultrasound fast scans for detection of retroperitoneal or extraperitoneal hemorrhage. Let us look at another scenario. This time, a 24-week pregnant patient was in an altercation. Vital signs were stable in the emergency room, but she complained of lower abdominal pain and cramping. The abdominal exam was benign, and there were no external signs of trauma. A fast scan performed in the ED showed a viable fetus with a heart rate of 153. Ultrasound images from the 4 quadrants do not show any free fluid. A fluid-filled loop of colon is present in the left upper quadrant. Ultrasound images additionally show a large ill-defined echogenic lesion in the left upper quadrant. Based on the ultrasound images, it was not clear whether this was a mass in the left upper quadrant or a large hematoma. Given the ambiguity, a CT of the abdomen and pelvis with IV contrast was performed, although it can be argued that an MR could have been done. And the CT images revealed that the echogenic lesion in the left upper quadrant was a large angiomyolipoma arising from the left kidney. So how good is a fast scan for detecting intra-abdominal injuries in pregnancy? In this largest to-date study from UC Davis Medical Center, in 2,319 women with abdominal trauma, of which 328 were pregnant, ultrasound had a sensitivity of 82.4% for detection of abdominal injury in pregnant women and 71% in non-pregnant women. The results of this study show a moderate sensitivity and high specificity of fast scans for detecting abdominal injury in childbearing women. They also show that the sensitivity of ultrasound for detection of abdominal injuries is not negatively impacted in pregnant women compared to non-pregnant women. Since physiologic free fluid can be present in the pelvis in pregnant women, the authors used the same data set to look at the significance of free fluid in the pelvis in women of reproductive age group. The data showed that in abdominal trauma patients, free fluid isolated to the pelvis was present in 39.5% of non-pregnant women and 20% of pregnant women. The authors in this study concluded that isolated free fluid in the pelvis is not necessarily physiologic in reproductive age women with abdominal trauma. Ultrasound is thus limited in the sense that it fails to identify abdominal injury in many women, does not identify the source of the pelvic free fluid or the severity of injuries in these patients. With respect to the presence of free fluid in the pelvis, the results of another study that was performed by the UCSD group are contradictory. The authors in this study showed that free fluid isolated to the pelvis was associated with abdominal injury only in 3.3%, and in only 1.8% the injury needed surgical intervention. Controversy thus surrounds the significance of free fluid in the pelvis in women of reproductive age group with abdominal trauma. In this slide, I present the imaging algorithm followed at UC Davis Medical Center for abdominal trauma and pregnancy. In all stable patients, fast scans are used as initial screen. A CT of the abdomen and pelvis is performed if there is gross blood in the urine, pelvic instability, neurological deficits, lumbosacral spine tenderness, free fluid seen on fast scans, and in some cases with abdominal tenderness or a seatbelt stripe sign. There are several issues that are unique to maternal trauma. There are several hemodynamic changes that result in pregnancy as listed in this slide, and as a result of this, substantial maternal blood loss can occur before vital signs are altered, and an apparently stable mother could be compensating at the expense of the fetus. CT should be used judiciously in pregnant patients with trauma. And UC Davis Medical Center data for the past 11 years shows that an abdominal CT was performed in 12% of pregnant patients as compared to 73% of non-pregnant trauma patients. So is there any role for MR in a pregnant trauma patient? To date, there are no published studies that have looked at this question. Challenges for MR in trauma include limited access to MR scanners, difficulty with MR safety screening in patients who are not responsive, monitoring of unstable patients in the magnet, long scanning times, artifacts resulting from fetal motion, and a learning curve for the radiologists. Further, the use of gadolinium is not approved in pregnancy. MR also has limitations for evaluation of free intraperitoneal air and bowel injury. Moreover, since intravascular contrast material is not used, there are limitations in the evaluation of vascular extravasations, pseudoaneurysms, or urinary collecting system injury. Further, optimal sequences for evaluation of abdominal trauma are not decided, although it would be logical that triplane T2-weighted sequence would be most optimal for the evaluation. The question then remains whether an MRI without gadolinium, with its challenges and limitations, is any better than a fast scan with its moderate sensitivity and high specificity and ease of access. When CT is done in pregnancy, careful attention needs to be paid to the CT technique to ensure the optimal radiation dose. The lowest possible setting should be used for the CT scout. Scanning should never be performed at 140 kVp. If an option is available in the scanner, the upper MA limit should be capped. The widest detector mode or collimation should be used. And finally, it is important never to scan multiple phases in a pregnant patient. The only exception to this may be to obtain a delayed scan through a region of interest if urinary collecting system injury is suspected, and this should be done at a much lower dose compared to the initial scan. Finally, if bladder injury is suspected, a conventional cystogram should be performed instead of a CT cystogram. We recommend having dedicated CT protocols for pregnant patients. The CT protocol for pregnant patients at UC Davis Medical Center on a GE64 detector and Siemens 64 detector scanner is shown in this slide. On the Siemens 64 detector scanner, we use a wide detector mode of 24 by 1.2. We do not use the 32 by 0.6 mode since it is less dose efficient. On GE scanners, we use a noise index of 18.5, and on Siemens scanners, we use a reference MAS of 140. On GE scanners, we cap the upper MA limit at 300, and that number can be dropped to 200 with a 40% Acer mix. So with these technique modifications, we can get a dose-optimized scan in a pregnant patient, as seen in this example of a 17-week pregnant patient scanned on a GE64 detector scanner with a noise index of 18. This resulted in an extremely low fetal dose of 0.7 rad in this patient, and the maternal CTDI wall was only 8.1. It is important to point out that this scan was done without Acer, and we can expect a 40 to 70% dose reduction if we add iterative reconstruction to the mix. Finally, there are some unanswered questions regarding CT dose in pregnancy. It needs to be determined how low we can go on the dose in a pregnant patient while maintaining diagnostic accuracy. The role of low kVp scanning needs to be established in pregnant patients. Studies using iterative reconstruction in pregnancy are pending. The fetal risks at ultra-low doses need to be determined to make better risk versus benefit evaluations. And finally, an important question that remains unanswered is whether dose modulation should be turned off in advanced pregnancy, since it has the potential for increasing fetal dose as the software senses a large maternal abdominal circumference. Thank you all for your time and attention.